Okay, I'll stay really close to the mic. I came out here because we're so far back over there. I feel too far away from everybody to at least say hello and welcome you all to this listening session. My name is Nancy Lane. I'm here on behalf of Secretary Sutters, who was not able to come today. And I have had the privilege of helping to facilitate these listening sessions throughout the Commonwealth. This is the last of the 8 sessions, and from looking around, I can tell you that this is the most well-attended one that we've had. So, go Gloucester. Honestly, driving up here today, I thought to myself, there's probably no more pleasant place to be on a day like this in Massachusetts than right here in Gloucester along the seacoast. So thank you very much for coming to spend some time with us. Before we get started, I wanted to have a special thanks to your mayor, Mayor Romeo Taken, who is here with us, and she is going to say a few words to us. Oh, and I meant to tell you that today is her birthday, so when you see her, be sure to wish her happy birthday. Happy birthday.
I think the governor set this up purposely because I wanted it so bad, so he did it for my birthday. That's how I look at it. First of all, thank you everyone for coming. I know that quite a few, we all work in this network. The reason why you see so many people coming here tonight is because we all work with one another. We all care about our communities and we all talk to one another. And we're feeling the struggle that we have with the behavioral health, especially juvenile behavioral health. We don't have beds, we don't have programs, we can't get therapists. And back in, Bruce, what was it? And Senator Bruce Tarr's here as always. What was it, in January, February, we had an emergency conference call with Mary Lou Sutters, Secretary Sutters, saying, you know, we can't continue this way. Children are going to school, and then when they not feeling well, let's say, they go to the ER, and some of them wait in 13 days in the ER, but there's no follow-up, and then they'll go back to school, and it's a recycling, the same exact thing, because our teachers are turning into social workers when they're supposed to be teaching. There's not enough social workers, there's not enough beds, there's not enough who's taking insurance, and when Secretary Sutter says it's not the lack of therapists, it's the ones who don't take insurance. So the remaining ones we're all fighting for. So there's 1,200 registered, 900 who don't. So the whole state of Massachusetts is fighting for those few. And we're saying, well, is it the pay? Is it the Medicaid? Because Mass Health, what do they pay? The connector, what's going on? And so there was a father who spoke. He said, look, I'd pay out of pocket to save my child. I have Blue Cross Blue Shield Gold, and I'm on a 6-month waiting period for my son at McLean Hospital. Then he says, I've changed 6 therapists. It's very difficult. Which, when the governor had his council here, we met again with Secretary Sutters and the Department of Mental Health. We stayed here about 2 to 3 hours to listen to people. And the same concerns are over and over. And my biggest thing is, and I'll be honest with you, 21 years ago, my husband took his life. And when he took his life, I said, he can't just die like that. I have to do something. And so along with Senator Kennedy, he showed me the ropes with Rob Strausser from Healthcare for All. I was on the Children's Coalition, and we fought to make mental health part of physical health. Because the problem is you needed prior authorizations. Every time you went for prior authorization, it could take up to 3 weeks. There's your meds, because you can't get your meds, so it's like, it was like a roller coaster until finally sometimes, you know what, like I call it, it's a disease you can't see. Depression, mental health is a disease you can't see, and what happens is, it could be like a cancer. You can go remission forever and live forever, but when it comes back, it can take your life, and that's what he did. I try to find a therapist for my children. I went also to 6 different ones. And back then it wasn't really welcomed as a disease, and they says to my smallest child that your father was selfish, and she lost it. It's not today. Everyone says that we all go, what are you talking about? But what's happening is, okay, so 21 years ago, I'm fighting the fight to find children's therapist. So what's happening? The children that are having those problems 21 years ago are now adults with children. So if you're gonna, and then they end up either hurting themselves, hurting others, or doing drugs, or all 3. And then they age out, and then a parent can't help their child. So what's happening now is 21 years ago to 21 now, not only are we supposed to help the parents, they're now the ones who are in trouble. We've got to help the children. So it's like it's recycling. And I told the governor, if we're going to stop the opioid crisis, you got to stop the mental health crisis. Because once they age out, parents have no control. If there's no beds now, well, they said there was no beds for opioids, and we found it. So together, hopefully today, you'll tell your stories and tell them what you've been going through or what you heard. It doesn't have to necessarily be yourself. It could be anyone or anything that you may observe, or any program you work with. Please, I ask you all to come here to be honest. We need to do this. The governor does these sessions so we can get the right programs in place. And the only way we're going to help our children and ourselves with this crisis is if we be honest and speak forward like I am today and speak about who you're dealing with and what's happening. I got great news today from Children's Friends and Family. They got a grant. The 3 ladies are here. A very good grant for 5 years to open a walk-in center from the ages of 16 to 25 in Gloucester. That's our first step. Any child can walk in and they can get services. There's no waiting. Children's Friends and Family takes Medicaid, et cetera. We're working on that. And that's great because that will be some of the after programs, but we still need follow-ups. We still need to help our teachers. We still need things in school because what I found out was shocking that children in 2nd grade are having anxiety attacks. Now, when we were in 2nd grade, I didn't like broccoli. That was the problem. I mean, I was a little chubble-up kid, and that was my problem, not anxieties. Who has anxieties? How do they have these anxieties? What's going on? As you can tell, the crisis is growing. So again, I want to thank Senator Tarr for being here because he's been here the whole time, every time I call. Today, I actually got a birthday call from Congressman Moulton, and I told him we were having this. And the 3 ladies were with me when Senator Warren called. And instead of wishing me happy, she said happy birthday. I said, well, you're not going to hear, this is what we're doing today. We're having a listening session, and we're having all these things happening. I really need you to do something. Okay, I know everyone wants to be president, that's fine, but what I need is mental health problem solved. I really need that for Massachusetts because can I tell you something? I don't care right now about 2020 because some of these children might not make it till then. And I have to help them. So thank you very much.
Well, thank you very much. That was a really impassioned way to start our time together. I also wanted to welcome Senator Tarr. Would you like to say a few words? Come on up.
Well, thank you very much, and good afternoon. And I also want to take a moment to recognize the representation that is here from Congressman Moulton's office. Thank you very much for being part of this as well. And I want to say thanks to everyone in this room, because as concerned as I am about the situation that we have with regard to behavioral health, which rises to the level of a systemic crisis, I'm also enthusiastic about the number of people that are here and your willingness to share critical information to help us forge a path to get out of the systemic problem that we have now. And I also want to say thanks to the panel for taking your time not only to come here to Gloucester, but also to travel throughout the state and hear about the situations that we have in every corner of the Commonwealth of Massachusetts. And then lastly, I want to say thank you to Secretary Sutters, who is a real champion for the people that the Commonwealth of Massachusetts serves throughout the Secretariat of Health and Human Services, and certainly those that are engaged in the behavioral health system and those that depend on the behavioral health system are no exception to that. So from my perspective, what we really need to do is find a way to create that kind of a comprehensive approach. In Massachusetts, we did pass a law for mental health parity. That was a groundbreaking thing to do and an important thing to do. But it means nothing if we can't execute that parity and make sure that people have access when they need it to behavioral health services. And I know that you're going to share stories with us today, and I'm so appreciative of that because those stories will move us to act and inform that action. But we've heard too many stories lately about children dwelling in emergency departments because there's no suitable placement for them. We've heard too often about lack of timely access because we don't have the kind of provider network that can yield that access. So we've got a lot of work to do. But the good news is we have people who care. We have a secretary who is innovative and motivated. We have all of you who came here on an August afternoon to be able to say, I care about this conversation, and I want to make a difference. And I'm confident that by the discussions that we'll have here today, and many more that will follow, that we all will make a difference, because it's up to us. And the Secretary has given us a great opportunity. And I look forward to working with all of you and our mayor, who has been such a champion on these issues from a place that comes from the heart. A real champion. Yes, thank you. And also our state representative, Ann Margaret Ferranti, who is also someone who's very concerned with these issues, and many, many more of my legislative colleagues. We have an opportunity in the face of dire need. Let's work together to take advantage of it. I know that we can, and I look forward to seeing us walk that path together to reform. Thank you all for coming very, very much.
Thank you very much. And before we get started, I have a couple of housekeeping items. First, if you would like to take advantage of our ASL and our CDI services, they're located here in the front of the room. We also have a Spanish interpreter here who is here, right here. I wasn't sure where you are. So if that is, if you would find that of use to you, please identify yourself and we'll figure out how to make that happen the easiest for you. The other thing I was asked to say is that I guess your police department has agreed not to give us all tickets for being out there. So I really appreciate that. When I drove around a few times thinking I've got to find some place that's more than 2 hours, because it's going to be, I'm sure they're going to come around at 5:45 and just give tickets to everybody, but that's not going to happen, so we can all stay as long as we need to and hear what everyone has to say. Let me introduce myself and the panel and tell you a little bit about what we're going to do today. I think I was introduced. My name is Nancy Lane. I'm a clinical psychologist, and I worked in Massachusetts for many years. I was the CEO of the Massachusetts Behavioral Health Partnership. So I've been immersed in the Massachusetts mental health system a long time. I left Massachusetts in 2015 and moved to Tennessee. I worked at Vanderbilt for a few years. I was senior vice president for population health and on the psychiatry faculty. And I came back to Massachusetts because I like Massachusetts, and I was really happy to come home. Right now, I work just as an independent consultant. So for me, I don't have a bias about what happens when this system gets redesigned. I really don't. I'm here to kind of be of service to everybody, to hear what you have to say and make sure that we have an open venue for listening. I'm joined today by a number of people from the EOHHS agencies who have also come to listen, and I'm going to, can't do the mic very well, but can you each just kind of shout out your names and where you're from? We're so far away back here. Go ahead.
Hi, Amanda Castle-Craft at Mass Health. I'm the Deputy Medicaid Director. Thank you for having us.
Hi, I'm Katherine Canada with the Department of Children and Services, where I serve as Assistant Commissioner for the Services Network. And I thank you all for taking your time to be here, and thank you in advance for sharing your stories with us. It helps us to plan better and to know what's needed.
My name is Matt Vino. I'm First Deputy Commissioner of Insurance for the Commonwealth. And I want to echo Katherine's comment. These sessions, I've participated in a number of them with my colleagues up here, and they have been enormously helpful in filling in our gaps in knowledge about gaps in the system. So look forward to hearing more from you today. So with the Division of Insurance, we oversee all fully funded commercial health plans in the state. So we enforce the mental health parity laws. We oversee carriers' compliance with the laws, occasionally take action to get them into compliance. And if there's time to do that, or the opportunity to do that, there are a number of specific projects that we've done in service to that mission for the division.
Hi, good afternoon. I'm Brooke Doyle. I got this very special chair here, so I have to reach over to say hello to you. I'm the Deputy Commissioner for Mental Health Services with the Department of Mental Health. I'm very grateful to be here with all of you today. Thank you.
Hi, my name is Deirdre Calvert, and I am the Director of the Bureau of Addiction Services for the Commonwealth of Massachusetts under the Department of Public Health, and I am a licensed clinician as well. I'm a social worker. I'm also very grateful to be here, and I find these sessions incredibly meaningful, so thank you for letting me be here.
Good afternoon. I'm Cheryl Lucier-Poppy. I'm the superintendent at the Soldiers Home in Chelsea, Mass. We have a long-term care facility for veterans as well as a domiciliary for some veterans who, through all different reasons, visible and invisible wounds, need some assistance getting back into the community. And I'm very honored to be here today and so pleased to see that so many of you have come out to share your story with us. Thank you.
Okay, I think it's the purpose of our session is pretty clear, but the title was worth repeating. This is about creating a behavioral health ambulatory system. If you've heard Mary Lou Sutter speak about this issue, she talks about the absence of a system, so that we're not really necessarily talking about, well, should we tweak one little thing, should we tweak another thing? It's like we really do need to put our best thoughts and our best ideas together to create a system that will provide the kind of continuous support and ambulatory care for people in the Commonwealth. This is an issue where there's a lot of interest, and there are a lot of people already weighing in on it. You may have seen Blue Cross Blue Shield put out a white paper. The Children's Mental Health Campaign put out a very big report. There are other people working on it. But Secretary Sutter's really wanted her initiative, the overall initiative, to start with all of you. And the listening sessions are the first stop on that, in that process. So the Baker administration, as you know, has done a lot of things since they came in to add to mental health services. They've increased provider rates. They've made telehealth easier. They worked a lot on the opioid crisis. They added opioid urgent care centers. There's a lot of projects that they've done and a lot of money that's gone out into the system. They estimate about $1.9 billion from 2016 to 2022 will be put out into the system. But yet it's not enough. Even with those, we've heard lots of stories from people about discontinuity, about not being able to find help, about finding help that's not helpful, and about the difficulties that they have navigating and accessing the mental health system. We've heard from providers about a number of their concerns and the ways that it's so difficult. This is such a difficult business to be in. So what we're going to do today, this is really a session to listen. We aren't going to talk at all once we get started. We're going to listen. I'm going to go back there. We're going to listen. And people are going to either make that, I don't know if we can use that handheld mic. Maybe you're all better at it than I am. But when you want to add something, just put up your hand and we'll either help you get up here to use this mic, or if we can use the handheld mic, we'll use that. And I also want you to know that we will stay as long as we need to. We don't have a hard stop at 6 o'clock. We're here until we're done talking. So don't feel that, don't worry if time is going by and you haven't had a chance to speak yet. We're going to ask people, if you can, that the first time you speak, if you can keep your comments to maybe 3 minutes or so that we can have as many people as want to speak. It doesn't mean that you can't come back and speak again, because you might hear something that somebody says that you think, gee, now I have an idea about that. So what we really want to hear from, we want to hear from consumers and families and providers and interested people and political people and anybody who is here who has something that you would like to share with us about either your experience with the mental health system, your ideas for how the mental health system should be, and any other things you want to talk about in this concept. I want to tell you a little bit about, That's going to be hard to read, but it's in your package. It tells you what is happening in this process throughout these months. This initiative was launched in May, and over the summer we've had these listening sessions, which have been really, really helpful, and you heard the panel say that. And think about when you're speaking that the people who are going to be working on this redesign are some of the people who are sitting here. So when you tell your stories and give your ideas, they're coming directly from you to them, not filtered through a report or something that someone does in an office. They're really directly from you. So that's why it's so important. The Commonwealth plans also, hopefully in August, to put out an RFI. An RFI is a request for information. It'll be another opportunity to send in ideas, respond to questions that the Commonwealth is thinking about in terms of how they should proceed. Later in the fall, they intend to issue a roadmap concept that says, okay, we've gotten all this input, we've put out our RFI, we've gathered all the information we can, and now we have a roadmap to where we think we are going to go. That'll be another opportunity to give feedback. And out of all of that, a plan will emerge to create a behavioral health system. A couple of other things I want to mention. I'm going to put up the questions just as prompts, and they're not questions that anybody has to adhere to or answer in any kind of order. They're just things to think about. But as we've gone around, we've realized that sometimes people don't think of behavioral health as including substance use, and it does. So we want to hear about mental health services, substance use services, and it includes all populations. And you can see from our being joined by a colleague who works in the veteran space, we've been interested in services for veterans. We don't have anyone here today from Elder Affairs, but they have been represented otherwise, and we're interested in issues of elders. We've heard a lot about kids, as you can imagine. So we're interested in all ages, all populations, all services. It's really an open field. So I just wanted to give you the broadest possible invitation to give us input. This very wordy document is also in your handout, and it really just outlines some of the areas that we are looking for input on. We're certainly looking for input on your experience as consumers, as family members. What's happened to you? What have you liked? What have you haven't liked? Is there something you've heard of or experienced someplace else, another state, another domain that you thought was really, really helpful that you think should be made available or should be included? Are there things you think we should get rid of because they don't work? Behavioral health outpatient specialty, we're interested in the biggest challenges you have in trying to access behavioral health. What are the bottlenecks? What are the barriers? We're interested in crisis services, like do you know how to get services in a crisis? Are they useful? Are they available? So those are the kinds of things we're interested in that you're really in the best position to tell us. So with that, and as I said, we're not going to say much. We might ask a question or two for clarification, but we will be here during and afterward. If you want to say anything to any of us individually, we'll all be around. And let's get started. So thank you all for coming. I'm going to turn this around now.
Hopefully I can do this within 3 minutes. Can you hear me now? Okay. My name is Chris Sadkowski, and I'm a parent of a son who has had numerous interactions with mental health and addiction recovery services in Massachusetts over the past 7 years. I have a number of comments, but I first want to make it clear that I appreciate the reform efforts being driven by Secretary Sutters and the attention she's given to these issues. In addition to being a parent, I'm also a very active volunteer with 2 NAMI affiliates, NAMI Cape Ann and NAMI Greater North Shore. One of the main points I want to make is that in trying to help my son and others, I found the mental health and addiction recovery system very difficult to navigate on behalf of my son, and I can only imagine what it is like for persons that are in a fragile and a vulnerable state. Back in October 2017, NAMI Greater North Shore held a public forum on mental health resources. We had an expert panel and a former state rep, Mary Grant, moderated. We received detailed feedback on 6 main themes, and they were HIPAA, emergency room issues, finding a psychiatrist and a therapist, insurance, additional challenges families and clients face, and compassionate quality care. I have a copy of that for the panel. I can submit that. And in looking at your current policy paper, I read through that. It looks like you as policymakers have and are familiar with these concerns, and I'm glad to see this reform efforts attempt to address those concerns. I know that numerous stakeholders events have taken place, and a lot of these issues have been put out there. The lack of integration and coordination of care and subsequent lack of better outcomes underscores the failings of the system, despite the many resources that are out there. Moving from one stage of treatment to the next is fraught with problems involving a variety of different providers and physical locations. When my son was finally ready for addiction recovery treatment, there was a maze of places to go, all while trying to maintain his methadone treatments as he moved to different levels of treatment at different physical locations. The paperwork involved for methadone providers was also always an issue, standing in the way of continued treatment. There was a CCS program, 5 days, then CSS, 7 days, then TSS, 14 days, and then a halfway house. Each provider was different and would move him along as best as my son could navigate openings at each successive level. Many options were also not responsive, even though they were within the same hospital system. With my knowledge of my son's needs and my knowledge of the resources in the system, he was able to move along successfully. Many people do not have an advocate to help. It would be nice if someone in the system was incentivized to play the role that I have played for my son within the system. My son's mental health care involved numerous emergency room visits and short acute care hospital stays. This was pretty much a revolving door for him and for the Massachusetts health insurance for years. I do have a bright spot to mention in the healthcare system, and I wish to highlight, and that's the integrated and coordinated care my son continues to receive at the Lynn Community Health Care Center. I cannot say enough about them regarding the integrated approach to addiction, mental health, and overall medical care that they provide. The other positive I wish to point out is the potential for the ESPs, the emergency service providers, to be a first line of care for mental health crises. When they are properly resourced and when the public is made aware of their services, they are a welcome alternative to the emergency room departments. In closing, my hope is that these reform efforts can somehow incentivize providers to care about individual outcomes and actually implement the integrated and coordinated care and follow-through that results in improved outcomes for persons needing mental health and addiction recovery services. Thank you.
I'll give this a try. Can everybody hear? Okay, so my name is Jenny Payne, and I wear a couple hats. My family, 2 family members. Nope. Hi, so I'm an advocate for 2 family members, one who's a resident here in Gloucester, one who's a resident out in Greater Lowell. And I also am an active volunteer with NAMI like Chris is, so my observations come from all of those 3 places, and I'm starting my timer now. I'm going to pinpoint things to the question about where would you go if your need was urgent, and the experiences that I know of about emergency rooms, and I'm going to focus it on, first, transport there, because this I know is an issue for other families like it is for mine. When your family member is in crisis, and you're wrestling with whether you're going to physically be able to get them to an emergency room, if an emergency room is warranted, can you safely get there in the car? Do you have to call for transport? The general public is not aware that that transport is limited. And if you have negative experiences with the ER that you are forced to work with, that is a disincentive for the person to interact and request transport. They will push themselves to have better options for their loved one. And that is the situation that I find with my family member in Lowell. It doesn't affect my experience, and I can't speak for the general experience here at Addison Gilbert in Gloucester. So that's the transport difficulty. And I'm going to say then with my NAMI hat, what I find is in the communities that I represent and work with in NAMI, police chiefs are frustrated when they also deal with these same unresponsive ERs, and they ask, why are we having this revolving door? My family member, who was floridly psychotic, was released after being sectioned. He went on walkabout in tornado weather, and he ended up back in the ER, thankfully, voluntarily. And he was admitted. He should have been admitted in the first place. But we have a hospital, I won't speak their name, that routinely turns people away, and that means that area police chiefs get very frustrated. I don't know what the experience is here in Gloucester for that one, but it's relevant in places in the state for certain, and your police chiefs will probably tell you about that. I mean, it would be great to integrate that information. Then when it comes to the bed search, here we get my Gloucester experience. My family member here is a Mass Health client. And so for the first time, I experienced what it's like to be a mental health patient who is a Mass Health client going to the emergency room. You are tiered, you get different service, you get different regard, it's delayed, the ER staff doesn't understand necessarily what the Mass Health civic system is, what their hours are, when you're going to be served. My family member was treated well. She was treated kindly, but no one could give us definite answers about when, in the 48 hours that we waited, we would actually be speaking to someone. At the same time that I was urged to leave, but I needed to be there to speak for them. So this is a broken system, and it's not parity. Thank you.
Hi, my name's Kimberly Flowers. I'm the clinical director at Elder Services, Merrimack Valley. I also oversee adult protective services for 28 cities and towns now, including part of the North Shore. I would like to speak on behalf of older adults, especially when it comes to the ESPs. Mobile crisis services do not work for older adults. Because when I have an older adult who is pretty much the only time that I try to access that service is when an older adult is at risk of self-harm. And basically we're always told, well, you have to get them in here, you have to get them to a clinic, they have to be willing to go. If I have an elder who's going to kill himself, he's not willing to go to the emergency room, I can tell you that. And they're very unwilling to go to the home to deal with any of that. The ESP system is broken for older adults, and I suspect for others as well. As you know, I think that the two people who spoke before me would probably also support. We need really to take a look at what we want that system to do, who it's targeted at, When I talk to those providers, I'm well aware that it's primarily targeted for children, and I think that's great, because I know that that's a population that really does need that help, but so do older adults. And the other piece is finding service providers for older adults is a challenge because of insurance, because Medicare is required for most of them, which is LICSWs, and there just is not enough people who can provide that service. For the SCOs, I can usually get other providers, and we actually provide that service through Elder Services Merrimack Valley and through Elder Services of the North Shore. But that's a very limited group of people who have access to those, because we're limited in the number of people that we also have as clinicians. So those are just two areas I really, really would love to see the ESP system overhauled, because that's the biggest challenge I think we have in the state right now for mental health. Thank you.
Good afternoon. I'm Sue Todd. I'm the president and CEO of Pathways for Children, Early Education and Care and Family Support Services. We are unique in that we have a staff of 11 licensed social workers working in our early education program, because we have to have them. The changes that I have seen, I've only been there 39 years. I started as a social worker, and it's really alarming to me. There are many populations that are less than adequately served, but the one I hear the least about as a member of NAMI and Child Welfare League of America, etc., are children. And when I say children, I do not mean those that begin in kindergarten and are having struggles in the public schools. I am talking about the infants and the toddlers that come through our door. I'm talking about our preschoolers. There are so many areas that we could be utilizing the state-funded, federally funded programs, early education and care, to begin to early identify, which we do, but there are not enough specialized social workers, clinicians that can focus on children and the environments from which they come. It has to be a multi-pronged approach, but we can almost guarantee, if we could throw the benefit of so many people sitting in this room now, and we have incredible relationships with our mental health providers and programs that we patch things together. But we really need the state's attention. I would have to say that I believe the early education and care system is in crisis. And you would hear this wherever you went. Our children are struggling with behavioral issues that we have never seen before. Opioids, many of the other things we'll be talking about today, that's what our children are living. A few years ago, 4 of our little Head Start kids lost their parent to an opioid overdose. You want to talk about trauma. So I appreciate the attention to that matter. And when we say children, let's not forget the infants, toddlers, and preschoolers.
Good afternoon, and thank you for providing us with this speaking opportunity. My name is Lainey, and I'm an active Learn to Cope member, a NAMI speaker to law enforcement from the family perspective, and a persistent advocate for my now 18-year-old son, and for what seems like an entire generation of adolescent substance users who are not getting the help that they so desperately need. Unfortunately, this demographic is growing exponentially. Our adolescent children, whose brains are not yet fully developed, have been empowered to override the recommendations of the juvenile court judges, the DCF social workers, their probation officers, and their parents. They're choosing a path of destruction that they don't realize will impact the rest of their lives, yet they're legally being allowed to sacrifice their future, their families, and sometimes even their lives. The CRA law that replaced the chins in 2012 restricts the courts from taking any effective action to help our kids. Our kids are now drooling, they're using high-potency marijuana with up to 98% THC, not the 2 or 3% that they want us to think they're using. They feel invincible, and they believe that they're experts in all substances, such that they would know if the cocaine they're buying on the street is laced with fentanyl or not. These kids are minors with brains that are not only not yet fully developed, but with brains that are seriously compromised because of years of substance use. They're minors who have been given the legal right to override the wisdom of the juvenile court judges after their parents have waved the white flag begging the courts for help. I am one of those parents. I've been advocating for my son and getting educated with Learn to Cope since my son was 15. He turned 18 in March. Probation advanced my son's CRA due to his unsafe behavior in the community. The judge requested that my son attend adolescent substance abuse treatment. And I'm sure you know there is only one for boys in the entire state of Massachusetts. Despite my son breaking into my house, assault and battery charges, and several threats to kill me and my husband, my empowered 16-year-old son chose curtain number 2 to just leave my house. Off he went with a DCF social worker for his first of 13 different adolescent group living facilities, none of which, to this day, has provided my son with one individual treatment session, not one. As of today, he's been to DYS, which is kid jail, 3 separate times, and he's currently on probation with the courts. However, there is no mandatory drug testing required in his probation. There's something wrong with that. As I mentioned, my son resided in a 90-day adolescent substance abuse facility. He was there for 80 days until he got kicked out for bringing in a beer. Yet even in that facility, he was never provided with individual therapy. Not one to give up, I made arrangements for my son to have individual therapy through the ARMS program in Boston. His residential program at that time, which was in Natick, decided after one appointment that these arrangements, them taking my son by car from Natick to Boston, was not financially a viable solution for them, even though they had promised upon entry to their program that they would help my son with his addiction problem. I could go on, tell you some pretty wild stories about conditions in the DCF contracted programs that my son has been in, including one that had black garbage bags hanging over the windows in place of windows or screens. Staff that confiscated substances from the residents and consumed those drugs while they were on duty with a house full of kids. And a group home employee who called me to report my son returning at 3 a.m. because the staff person in the group home couldn't find the number to the DCF hotline. I even know the number to the DCF hotline. We had a clinician who advised she was forcing us to take our son home for a visit, despite our son's pending charges for assault and battery and threat to kill us. She told my son he was not an addict and he could be an occasional smoker. That was one summer ago. My son has gone downhill very fast since then. So what can we do to improve the situation for our mentally ill adolescent children and their families? The first thing is we need to have services available to the under 18 crowd. As I said, right now there is one residential facility that will provide services to adolescents, adolescent males under the age of 18. There needs to be more. What else can we do? DCF must be accountable to someone other than themselves. As I understand it, from my phone calls to the Ombudsman's office, many of them, the only thing the Ombudsman's office will do is refer the complaint to the next level of supervision. I can do that, and I have done that. I've gone to the area director. My social worker missed 3 consecutive bi-monthly meetings with my clinician, when my son was in a STAR program. He never even told me that there were meetings. It took our social worker 13 months to figure out how to obtain a peer mentor for my son, something that my son requested, not his parent. DCF refused to file a 51A on another parent who proudly told DCF that she knowingly harbored my son for 16 days while he was listed as missing by DCF and with the police. What else can we do? We need to separate or provide better controls between DCF and the organizations with whom they contract for services. I've been told, and I don't know if it's true, but I've been told that DCF pays these residential facilities $500 per day per resident, yet they tell me that they have no say in the treatment of the residents who reside in those facilities. In my opinion, DCF is the client. They are purchasing a service from these facilities, and they're not holding the facilities accountable. We need to bring back the CHINs and replace the CRA. And I think if you speak to law enforcement, the judges, and probation, they will agree. We need to take the decision-making out of the hands of the children and give it back to the courts. We need to give juvenile court and probation the ability to impose meaningful consequences. My son turned 18 in March. He signed on with DCF as a VPA, that's a volunteer. They gave him 90 days notice because he didn't agree to stop using substances. That expired on June 10th. My DCF social worker is still trying to arrange a meeting from June 10th, and I believe today is August 14th. That's 2 months. We have not yet had a meeting. However, back in June, I was told that my son is not abiding by his agreement because he comes back at 3 a.m. and he continues to use substances out in the community. Which leads me to another point that we need to change. None of these facilities are required by law to have Narcan on hand. The airlines are now carrying Narcan on every flight because I believe about 4 weeks ago, one gentleman was taken off of a flight in a body bag because he overdosed. You have groups of children under the age of 18 living in group home facilities. 90% of them are abusing drugs, and there is no requirement that I have confirmed with the EEC. They are not required to have Narcan on hand. My son's program director confirmed that my son continues to get high every day, but it's out in the community, so they don't have a need to have Narcan in the house. There's something wrong with that. We need to educate the service providers. I am tired of hearing it's only marijuana. It is not only marijuana. It is 98% THC, and it doesn't go anywhere good. My son has progressed. He's now doing cocaine and mushrooms, but it's only marijuana. I also think that every town's law enforcement should be required to participate in mental health awareness training and to learn how to deal with substance issues in the community. My town, I'm sorry to say, I love my town of Marblehead. It actually looks just like this in Abbott Hall. But the officials in my town are in complete denial. They do not participate in any mental health training for law officials. I attended last week a hub meeting in the city of Lynn, to which Marblehead has been invited. Swampscott attends, Marblehead chooses not to. The hub meeting, if you're not aware, is a meeting where multiple agencies meet and they try to help those who are in need and need services from across the spectrum of the agencies. It was a beautiful thing. Why are towns not participating when the services are there? Why are towns not taking the grant money that is on the table that can help them to keep their children alive and stop having overdoses in the high school cafeteria? They should be forced to participate. I mentioned that I'm a NAMI speaker to law enforcement. Marblehead does not participate in that either. Marblehead also doesn't participate in the diversion program that I believe Gloucester participates in, along with Beverly, Manchester, Essex, and Rockport. They have a mental health person from Leahy who rides with the police and attends any mental health calls that come into the police or the fire. Every town should have these services. The only other thing that we can do is to keep having meetings like this so that we, the residents of the Commonwealth, can share with you our concerns. So I thank you so much for the ability to share with you how you can help our kids to have a healthy and viable future in this state.
Good afternoon. My name is Chanel Robinson. I have a 10-year-old youth. We are from the city of Beverly. I'd like to touch on two topics that a couple of the ladies already touched on. One is transportation. Unfortunately, I have not had the best experience with transportation. There was a time, a couple years ago, my son was admitted to Salem Hospital for psychiatric purposes. So he met the criteria for emergency psychiatric services, not inpatient, but CBAT. I don't know if there are parents familiar with CBAT. So I got the call that said, hey, time to go. We got to pack his bag, get him to go. And I said, okay, well, I can transport. And they said, no, he has to go by ambulance. And I said, okay, well, I will meet them there. A year later, I received a $3,000 Cataldo bill for that transportation and was told because it was not from hospital to hospital, it did not count as an emergency situation. So I quite baffled as in how a child who has been admitted into the ER for psychiatric reasons does not, excuse me, how does that not constitute as an emergency? I'm a single parent. Yes, I work and I make very, very good money, but as a single parent, a $3,000 Cataldo bill is way out of my budget. Something else I'd like to touch on is just helping the local emergency services better understand our youths. As said before, there are a lot of communities that do work well. Thank you. I'm sorry.
That's all right. That's what we're here for. We're crying with you.
My son is at St. Anne's right now, so it's kind of hard. But the Beverly Police are great when you call and say, this is an emergency, this is a mental health situation. Now, I've had experience in the past where, I'm not going to name the city, where my son, he has a very high level child, thank you, severe behavior, assaultive behaviors, and they had to pull over the school bus because he and 3 other youths had attacked the staff. So the police were called and I had to leave work and I showed up and the officer looked me in the face and said, ma'am, what goes on in your home? So some of these emergency providers I think could benefit for just a little bit more humane treatment of us caregivers. We're not bad parents. We have kids with problems. And to have somebody say that to you and look at you like you're scum and it like basically treat you like you abuse your child or like you just don't discipline them enough or the right way, it hurts, you know, not to throw this out, you know, come off as better than anyone, but I'm a college graduate. I have 2 degrees. I'm a chef. I work hard, you know. I have raised my son on my own since I brought him into this world. And I have gone through the revolving door, as many other parents have, with mobile crisis, ER, CBAT, inpatient. And when your child is in crisis, there's so many things going through your head. There's guilt, there's Payne, there's here we go again. And to have somebody who's supposed to be there to help you basically denounce you, it just makes the situation worse. And my last point I wanted to touch on, there are some really good programs out there, and I thank you, but there's not enough. My son right now is at St. Anne's in a CBAT because he is going through another round of mental health crises. Now, like I said, I've been through the revolving door. I have gone through hell and back with that little boy, and I have wanted to raise the flag and to say, I quit, I'm done, I'm tired, I can't. But at the end of the day, I can't because I still have to be mom. So when we have these situations, there's just not enough beds out there for these kids, and there's so many programs that have closed. My son is under the age of 13, so he's not a teen. So there's so many programs that respectively are for severe older adolescents, but my son started these behaviors at 4. And my son at one point boarded in the ER for 8 days because there were no beds across the state, and there were 21 children at the same time waiting for a bed. And it got to the point where I don't know what the name of the bed was, but they tried to enclose him in a bed, and it didn't work. They got to the point where they were strapping him to a bed and, shooting him with trazodone, and that's very barbaric for, at the time, a 9-year-old. They don't understand why they're there, what they did wrong in some cases, and there needs to be just a reform, I guess, in particular, how we are working with these kids when they are in crises, because strapping a child to a bed is just, I understand there's situations that warrant a different action, but I think it's just barbaric to do that. And then, my son finally got a bed at Providence Hospital. It is like the only psychiatric hospital in the state of Massachusetts, and it's 2 hours away. So I had to drive every other day to visit, to have psychiatric consults, everything, to Holyoke, Massachusetts to see my son. And mind you, half of the youth floor was closed. So they only had 7 beds. How do you have 21 youths fighting for a bed and you have a whole wing that is closed, and these children are still being strapped to beds and chemically, put to sleep to manage behaviors? It's a disservice to these kids, because it actually just creates more trauma for some kids that already have trauma, and my son is a child with trauma, unfortunately. So it would be great if we could see some changes. Thank you.
Hello, my name is Scott Trenti. I'm the Chief Executive Officer at Senior Care, Gloucester and Beverly-based aging service access point and area agency on aging. And I want to speak to you a little bit about seniors and older adults and their needs relative to behavioral health, treatment, intervention, and so forth. I've worked in the field for the past 25 years, the first 13 of which I worked in elder protective services. And what we've consistently seen over time is an increase in the frequency of behavioral health situations, as well as crisis situations, as well as comorbidities, where there's medical issues also present along with the behavioral health issues. I want to identify some barriers and some potential solutions, or part of a solution to the overall problem. Many of our seniors and older adults are reluctant to go to outpatient treatment. That may be due to a variety of reasons. It might be due to ambulation issues. It might be due to their physical condition, or it might be because they're ashamed and they feel that there's a stigma attached to seeking mental health or substance use treatment. One of the solutions that I see and that we've tried to implement at our agency is to find therapists who will conduct home visits, to provide therapy in the home. Now, I want to flash back to around 2007, and our Mass Home Care Association really pushed forward on the needs for behavioral health treatment, and it became what is known as a purchase service. So it's part of the menu that our case managers could authorize. Okay, so we all contracted with outpatient providers. But if that senior in the home had mass health, those providers didn't want to go to the home because the rate of compensation to them, in addition to the expense of travel, it wasn't worth it to them, so they didn't do it. Okay? Third-party billable in Medicare is a different story. We're fortunate at senior care in that we have 5 licensed therapists, that we have partners. They're not employees of senior care, but they will, in fact, conduct home visits. And it's been proven to be successful. Another issue that can impact outpatient services is transportation. We have CADA here, which is great. We have Topsfield, we have Ipswich, Hamilton, Wenham, Beverly. And transportation can be difficult for some elders, especially if they need, for instance, a wheelchair van or something like that. So that's another issue that can prevent them from seeking appropriate care. I want to echo my colleague Kim Flowers from Elder Services of Merrimack Valley. Where are you, Kim? Hi, Kim. Of the broken ESP system. So we see this often in protective services where a caseworker will assess someone to be a danger to themselves and others and need to try to seek emergency services. That could be through the physician who can authorize a Section 12. It could be through the police department that can authorize transportation to the hospital under a Section 12, or it can be someone going willingly. The system is very broken. It's time consuming, you don't get a prompt response, and people are at high risk. And I have seen situations where it's taken a turn for the worse, quite frankly. So that's something that definitely has to be addressed. Another thing I think is really important, and I never quite understood this, is in the Department of Developmental Services and Department of Mental Health, med techs are allowed. These are folks that are trained to assist people with taking their medications. We don't have that ability with elders, and oftentimes folks are taking their medications, including their psych meds, incorrectly. They also might be taking the medications for their medical conditions incorrectly. This can lead to more ER visits, more hospitalizations, etc. So I would say to consider allowing our system, Elder Affairs, to look at the possibility of letting med techs go to a home, assist an elder to ensure that they're taking their medications properly. Along these lines, physicians don't always talk to each other. So let's say an older adult has a prescribing psychologist or a nurse practitioner or a physician assistant, and they've got a primary care physician. There's no guarantee that these providers are going to speak with each other. So perhaps a senior is put on a benzodiazepine, okay, something like a Valium, but they're also taking other conditions, other medications for their medical condition. There can be complications and adverse interactions when this happens, so it's very important that providers speak to each other. I think we've made a lot of progress recently with the introduction of electronic medical records and being able to share information between providers, but it's not across the board. It's not in all cases, and it doesn't involve all providers. So I think that is something that's very important as well. Training. Training is also very important. So our local police departments, not to be biased or anything, but I think they're pretty awesome. We really utilize the Alzheimer's Association for first responder training, not only for police, for fire, for EMS services and other first responders. But there's also something called mental health first aid, which is a 2-day training, Leahy here at Addison Gilbert and Beverly Hospital have folks that can provide that training. I think that's equally important. In addition to how do you help someone with dementia, how do you intervene, how do you de-escalate, same thing with folks that have mental health issues. So I think that that's something that first responders should certainly embrace, if not be required to take. I know that Leahy did this in the school system last year or the year before. We got to be mindful of the fact that, you know, I feel that the emphasis is on children and younger adults, but these children and younger adults are going to be older adults someday. So the earlier we're able to intervene, the better. The other thing is access to treatment. You know, I identified some barriers. Wouldn't it be nice to, if, you know, we have urgent care now, wouldn't it be nice if there was an urgent care, a part of urgent care that was able to help someone who's in a crisis situation, as opposed to having to go to the emergency room, sit in a chair for 13 hours, and be discharged home. So I think that that's something to be looked at, an intermediate step prior to having to run to the emergency room. The other thing is inpatient hospitalizations. Most typical psychiatric hospitalizations or substance use facilities are not geared toward elders. We are very fortunate here in Gloucester that we have a senior adult unit at our Addison Gilbert Hospital, specifically for older adults. That is a charm. That is really great, and I'd love to see more facilities like that where you have specially trained people in geriatrics who are assisting older adults in helping them. I thank you for listening, and I hope that these sessions were helpful for you and you got a lot of good information that you can bring back. And I look forward to your RFI as well. So thank you.
Okay, I've been asked, it was brought to my attention that look at how long the line is of people who want to speak. This is terrific. But the more people are in the line, the more I need to ask you if you can kind of speak really fast when you talk so that we can make sure we get a chance to hear from everybody. I haven't wanted to cut people off because people have really important things to say. So as the line gets longer, if people can kind of try to condense your statements, that would be really helpful to all the people here. So, but take the time you need. Thanks.
Great. My name's Stephanie Slayton. I'm the Executive Director of Children's Friend and Family Services, which is a division of JRI. And we have sites across Essex County, including a wonderful outpatient clinic here in Gloucester. I've been at Children's Friend for 5 years, in which time we've doubled our staff from 150 to 300. Sad to say, I can also stand here and take responsibility for clinics that have wait lists with over 100 individuals on them, specifically in the communities of Lynn and Lawrence. Linguistic challenges, having people that have the ability to stay in the job as a clinician, listening to the horrific layers of trauma that the individuals and families that we work with have experienced is very challenging for our staff. Some of the key reasons that people face wait lists include this challenge in recruiting and retaining master's level outpatient clinicians, especially those who are bilingual and bicultural. Many leave due to the high caseloads that they have to hold, which is up to 40. The vicarious trauma, as I mentioned, that they experience, and many leave for other mental health jobs. They don't leave to do other jobs. They love what they do, but they leave to try to find jobs that have less burdens on them. They don't have a paperwork restriction, the paperwork burdens or the productivity that we do. So they leave and go to DCF or private practice or to the few coveted school jobs, all of which pay significantly more than outpatient clinician jobs in a community-based setting, $10,000 to $20,000 more for starting clinicians in many of these jobs. We can't compete. We provide outreach and go into people's homes, and we do it at a loss. We made this decision because we believe in the principles of the Children's Behavioral Health Initiative, and we truly think that meeting families where they're at and in their own homes provides access to care. But we don't have additional rates that support our clinicians' time and traveling from home to home out in the community. We just do it because we know it's the right thing to do. We know there are other barriers as well, including burdensome documentation put in place by our payers and various structures, the time frame restrictions and lack of ability to bill for engagement on the wait list. But what I do want to share are a couple of solutions or things that really do seem to be offering some hope in our community. Creative, flexible programming, such as the Now is the Time Healthy Transitions grant that has been a partnership with the Department of Mental Health and VinFen. We have opened a drop-in center in Lawrence called U Forward, and it's been an incredible success. But the whole time we've struggled with what we would do at the end of 5 years with regards to sustainability. We're on the front step of opening our second drop-in center here in the community of Gloucester, and we cannot be more happy. We knew this was the right community to do it. We knew that this community was ready because we've seen other solutions that work in Gloucester. Things like working together on the local level, such as the high-risk review, and allowing clinicians in so that we can hear and offer suggestions and be right there so that we can jump in after the meeting to offer solutions. Other things that are helpful would be specialty short-term treatment for individuals that are sitting on wait lists. If someone's sitting on a wait list for 6 months, 8 months, and they've experienced something traumatic, we've totally blown it, and we're actually creating a worse problem than originally happened. Well, thank you. Individuals may be coming to us with mental health challenges, but by the time we get to them, literally some are homeless because they have experienced challenges with keeping their employment because they get called out of work to go to school to answer questions about why their child isn't functioning or behaving in an appropriate way in class. And I really think that there's a lot of things that we can do while people are sitting on wait lists, but there's no funding structure right now to do that. If we were able to train clinicians in short-term evidence-based models and provide even short-term treatment while people are waiting, we may be able to prevent some of those things that get worsened while somebody's sitting on a wait list. We still can get to the point of doing outpatient therapy on a longer term with them, but we have to do something in the meantime while they're waiting. I also think that more opportunities for peer support is critical. Our drop-in centers have been extremely successful using peer mentoring models. Those are individuals with lived experience who can immediately partner with people that are going through it at that very moment. We very much so appreciated our partnership with BSAS, and in particular with Rebecca Butler, who has partnered with us to get multitude of individuals at Children's Friend trained in ACRA and prevention models for substance use. One of the challenges that we have faced, however, is we can't access the actual funding that we've been awarded through the contract because the state's virtual gateway system has been so burdensome and complicated. We have recouped $300 in the course of a year to pay our clinicians, and we have, in the meantime, been allowing them to do the work, again, because it's the right thing to do. We need rate reform to support higher pay for our clinicians so that they stay, so that people don't have 5, 6, 7 clinicians over the course of their childhood. People need to be connected with people that are going to stay. And that's all I have to say. Thank you.
Good afternoon. My name is Officer Chimoshka with the Gloucester Police Department. I work the 4 to midnight shift, and as you all know, on our daily basis we deal a lot with behavioral health issues. We're usually the first point of contact in a crisis. We go into a lot of calls with very little information, and we try to do the best of it. Personally, I've been working for 7 years, and before that I've been a social worker at a behavioral home for kids, which was a residential placement in Salem. And right now, I do a lot of community policing. I go to a shelter all the time and just try to get involved with the members in the community, get to know them. So for us, it helps a lot to know the people that we deal with and kind of know their history because it helps us to better understand their problems and find solutions in a time of crisis. And nowadays, police departments have kind of leaned towards that way where we know that behavioral health is a big issue, and there's a lot more training provided for that. I personally went to a lot, such as the crisis intervention training offered by Leahy was a 5-day training, gave us a lot of resources. But in the end, I feel like the biggest issue is that when we respond to these calls, there's very little resource at that time, so we just got to use what we have, and a lot of times we just use our great paramedics. And I feel like it's just a short-term solution where we respond to the crisis. It's kind of like putting a Band-Aid on it, where we just call the squad and the person, goes to the hospital and gets evaluated. But then maybe they get sectioned, maybe they get kept there for a couple of days, but then again they return to the community within a short period of time, and the same issue happens over and over. So what I would like to see mostly is some kind of longer-term solution that would help out a lot, because honestly it's kind of heartbreaking just to put somebody in an ambulance, send them to the hospital, and see them in the next 2-3 days and do the same thing. I feel like it's just, kind of not working right. If there was something a little more longer term, especially for kids, when we deal with a lot of kids, they don't want to go to the hospital, they don't want to leave their house. So if there was different solutions to that would help them stay in the house but also get the help they need, that'd be great. So that's about it. Thank you.
Hello, thanks for having us. My name is Patrick and this is Allison. We're both paramedics with the Gloucester Fire Department. We have a very unique view. We're the ones that respond to any type of 911 call or emergency request for aid for anybody having some type of behavioral health of any age. We kind of are the first step, the first ones to meet that patient before they enter into any type of further behavioral health treatment, whether it's in the hospital or some type of specific treatment center. One thing that we see on a daily basis is that we continuously run into the same people. The same people are having the same problems, and we start by bringing them to the emergency room, which is also another concern. A lot of our patients that are having behavioral health emergencies, they don't have access to beds in a behavioral treatment center, so they get held up in the ER for actually days at a time. Here in Gloucester, I've seen patients 3-4 days in the emergency room being held, waiting for a bed. A lot of the times they grow impatient, and the interactions with the hospital staff who are there to try to help them become pretty negative, as these people don't want to be held up in the ER, and so they end up kind of abandoning their quest to seek help and leaving the hospital, and then we run into these calls again, and we basically start back at zero again. So any help that we're trying to render to people that are seeking help for their behavioral issues, unfortunately, it almost stalls out kind of at the next level, and we end up seeing a lot of this kind of repeat thing. So it would be, what we would like to see is a little bit more accessibility, I guess, in the next step after the emergency room. We only have one point of entry to transport people to when they request help from us, and that's the emergency room. We don't have the ability to go anywhere but a hospital's emergency room. At a previous place I worked, we had the option of transporting to a psychiatric-specific ER. It was attached to a medical ER, so they had that kind of back and forth if needed, but the process was much faster, more streamlined for that specific need, psychiatric behavioral need, which we don't seem to have up here in Gloucester and on the Cape, at least something that I, as an ambulance operator and paramedic, can't transport a patient to. So I'd like to see that bed accessibility opened up, get these people out of the ER into help faster, avoid kind of that negative interaction with the hospital staff. Thanks. Days on end in an emergency room. No patient suffering from cardiac issues or an infection stays days on end in an emergency room. They're in there for a few hours to be stabilized, and they move up to a floor. I've seen people in the emergency room here for 3-4 days at a time waiting to get a bed. That needs to change. And then I would, some type of, I guess, some type of way to prevent kind of the repeat issues that we're having. Something's not working. We're seeing the same people for the same reasons day after day. So those two things, I guess, were the two issues that we see that we wanted to bring up. And we're also very happy to be here because we get to listen to some of these other stories, and we see that too, and we want to hear what other people's concerns are, knowing that we're going to be kind of the first step in this process for those that call 911. It's valuable information to hear your concerns, and if there's something that we can do better, we're definitely going to try to do that. So, thank you.
Okay, we're going to do something slightly different. We're going to, so people don't have to stand in line, I have a list now of everybody who wants to speak. So I'll call your name when it's time to speak, and I have a couple of just quick things. It's 5:30, and we can certainly stay beyond 6, but there are now like 17 people on this list. So again, if you could scrunch up your remarks, and if you have brought written materials, we also, I neglected to say this, but there is a website. It's, we'll put it up at the end. It's also in the materials you got. And I hope that any of you who brought written materials will also submit them to the website. You can give them to us, and we'll make sure they get there as well. So that's another way to interact with us. So thank you. Go ahead.
Hi, thanks. My name is Tim Como. I'm the Behavioral Health Director at Merrimack Community Health Center. I'm also a licensed social worker, licensed alcohol drug counselor, and a trained trauma therapist. I just wanted to talk for a moment about the inpatient setting and the discharge process. Ideally, when somebody goes inpatient for mental health reasons, they would be discharged with a reasonable plan for follow-up that would include counseling and psychiatry. Working within a primary care setting and doing the best we can, it often happens that the discharge plan, due to lack of access in the community, is discharged to primary care because that's a prescriber. However, what it does is it leaves primary care providers overwhelmed with complex psychiatric medications that have only been written for a maximum of 30 days, and they're totally overwhelmed, but they can't get psychiatry in the community quickly enough. We're doing the best we can within community health centers, doing things like telepsychiatry. We're doing innovative things within community health centers like telepsychiatry, like bringing on psych providers when we can. However, that still does not address the issue that inpatient discharge plans need to get people connected to counseling and psychiatry in the community much quicker without the reliance on primary care that's not prepared for those complex medications. Secondly, we do a lot of warm handoffs within primary care. And so myself, I'm a 14-year experienced, duly licensed clinician. I met with a high-risk patient yesterday within primary care for 10 minutes for a very critically important warm handoff. I spent 25 minutes of my time on it, 5 minutes to prepare, 10 minutes face-to-face with the patient, and 10 minutes to document and work with the team afterwards. We will not get reimbursed for that because I didn't spend 16 minutes or longer face-to-face with the patient. That's a problem, so the recommendation would be there to lower the threshold on the time spent in a warm handoff session like that. I would say 8 to 15 minutes should be another category of reimbursability for that. That helps reduce risk. It helps crisis planning, and it helps bring people back because they've met a social worker face-to-face in the primary care setting. We appreciate the progress that's been made in terms of telepsychiatry reimbursement, at least in community health centers and some other settings right now. We've got to keep exploring these innovative ways to have psychiatric support available to our vulnerable patients that need it. And what I would say is we need to continue on that journey of innovative ways like psychiatric e-consult, where they review a chart without the patient being seen. The patient gives consent to this process, and it offers the primary care provider the ability to get support from a psychiatry provider and tweak the medications, but that's got to be reimbursable, because if it's not, then as soon as DSRIP or other grant funding expires, that service will expire for those of us that are providing it. And the other thing I would say is that as a community health center with a new behavioral health department since 2018, our goal is to fill in the gaps. Now, ideally, that would mean that we are using all of the large behavioral health agencies in the community and quickly connecting people to counseling and psychiatry, quickly making connections post-inpatient discharge. However, the fluctuation of availability is so great that we're growing within the community health center. That's fine, that's a good service, but we shouldn't be growing because of the consistent fluctuation at the behavioral health agencies in the community. You take one agency that loses one prescriber and you go from like a 2-month wait for psychiatry to a 6-month wait, sometimes no access at all. So there's got to be more consistent access. So thank you for your time.
Okay, Brigida, right?
Yes. Hi. Thank you for the opportunity to provide comments. I come to you from two perspectives. I serve as the CEO of LEO, the community action agency that serves Greater Lynn, and I just want to emphasize the comments that were made by my colleague Sue Todd regarding the need for mental health services for early education and care children. We serve children birth to 5. We serve 600 pregnant women and children, 45% of whom have experienced trauma, and those are the traumas that we know of, and that's trauma on top of poverty. And what we find is when we need to provide the comprehensive services for the family, for therapy and so forth, there are long waiting lists, as many people have said, and we have recently added a social worker to our staff. We used to contract out that service, but because the need is so great and it's almost doubled since last year, we have needed to provide those services ourselves in-house. In addition, I am a foster parent. I became a foster parent in May, and being in health and human services for my entire career, including working with the Commonwealth, I found myself lost in terms of trying to find services for my foster child. She came to us experiencing trauma, not only in the home, but obviously being removed from the home and being placed with us. Not that we're traumatic, we were very warm and welcoming. But because she had mass health, I was lost in trying to find a therapist. I finally contacted my own EAP, who did put me in the direction of a therapist, but then there was a long waiting list. So to DCF, I really urge you to have some type of system where there is urgent services needed for children that need those services right away. She herself was asking for that, and I was lost every day trying to provide her with some level of comfort that it needed to be through a therapist. So thank you again for this opportunity and for listening.
Okay, we have Colleen. Thanks.
Hi, my name is Colleen Brown. I'm the public health nurse for Manchester. But for 32 years, I was an inpatient psychiatric nurse I worked at McLean, I worked at Beverly, and I ended my career at Mass General. I was very blessed to do a job I loved for a very, very long time. What I saw when I was an inpatient nurse was that we were forced to discharge patients with bridge appointments, hoping that they would get a therapist. There were very few resources available to them. When we lost the Long Island shelter in Boston, we were sending more and more patients to the streets. More and more patients were living under the bridge, drinking, smoking spice, just getting into more trouble. There are not enough beds anywhere for these folks when they're not in the hospital. It just doesn't work. 4 years ago, now I'll tell you a different story. My husband had a brain aneurysm, and it was sudden and catastrophic. At the time, my son was 8 years old. As our life kind of fell apart like a house of cards, my son came to me and said that he was suicidal. Something a psychiatric nurse never wants to hear from her child. But I thought, I can manage this. I belong to one of the biggest systems in the state, part of Partners, part of Mass General, #1 in psychiatry in the country. I brought my son to the ER at the General thinking that would be the quickest way, given my connections, to get my son treatment. I was wrong. After 8 hours in the ER, and believe me, they moved us fast. It was a Friday. They could not get my son an appointment. They came to me late in the evening and said they planned to admit my son to Franciscans. And I said, well, why would you admit my son? And they said, well, he needs to be safe over the weekend. We can't get him an appointment. We're going to put him in an inpatient bed. I said, I'm a psychiatric nurse. I've worked for 32 years. These guys that were going to admit him, I trained them. They were residents on my floor. I can take care of my son. But they could not get my son services. So the trade-off was I needed to take my son out against physician's advice. They wanted me to bring him to a day program starting on Monday in Jamaica Plain. Now, if you know, I live in Manchester. Think about where Jamaica Plain is. I have a husband who has a traumatic brain injury, and they want me to get my son to Jamaica Plain at 8 o'clock in the morning. I'm lucky if I can get either one of them up at 8 o'clock in the morning. What I would say to you is there are no day programs for any of these kids. Why do I have to drive to Jamaica Plain? Why do parents have to drive to New Hampshire? Rather than inpatient units, if a mom could bring their child from 9 to 2 to a program where there's psychiatry, where there's groups, where the kids can learn a healthier environment, that's what we need. We need that in outpatient programs. We don't have any of it on the North Shore. We don't have any of it north of Boston. It's important. And fortunately for me, I had colleagues that I could call that night and say, help me. And I was able to find my son a therapist. I had great insurance. I had all the things you needed. And the system that I worked for all those years failed me. And so if it fails me, what does it do for people that don't have those connections? And so, well, I think inpatient beds are really important, and I will, having done it for so many years, I would focus on outpatient programs. I would focus on day treatment. My husband at this point has dementia. I will give a shout out. He goes to an amazing day program in Gloucester called Day by Day. It has psych patients, patients with TBIs, dementia. It is an amazing program. It is run, it has counselors and nurses so that if my husband needs to take meds or have a shower, he's assessed daily. That's a great way to spend money for the state. It's a wonderful program. And so I would encourage you to think sort of out of the box in that kind of way. And thanks for listening.
Okay, we have Savannah. Did I say it correctly? Or is it Sarah? Must be Sarah. But I can't read this person's handwriting. I'm sorry. Well, thank you.
Hi, there we go. Hi, I'm Sarah. I work with the NAN Project, an organization that challenges the stigma surrounding mental illness by starting conversations about mental health in high school classrooms. Our team uses their own lived experiences to teach students about the many ways mental illness can manifest in our behavior and some ways they can help themselves or a friend who might be struggling. What I hope to do today is propose a little bit of a change in attitude in outpatient care. I struggle with anxiety, depression, PTSD, and I'm recovering from an eating disorder. I got my first diagnosis at 15 when I began seeing a therapist, but my symptoms had been affecting my ability to function in school and my relationships for years before that. I have been in the outpatient mental health care system for the better part of 10 years, so I'd say I'm pretty familiar with it. During that time, I've seen several different professionals, counselors, therapists, nurse practitioners, psychiatrists, and most of my experiences have been really great. I'm lucky that it's been easy for me to access care. I'm lucky that I've been listened to in regards to what helps me and what doesn't. One thing I would change, which has constantly been a hurdle from the time I began my treatment to now, is weight discrimination. At my lowest point in my mental health journey, I was 16. Years of negative feedback about my body from both peers and the adults in my life, as well as my own anger that I tended to direct inwardly to myself, resulted in a completely abysmal body image. I was in the habit of starving myself until my body couldn't handle it anymore, eating something small to tide me over, and beginning that cycle again. I quickly dropped weight because of this, but the peers and the adults in my life weren't concerned. They took this as a sign that I was taking better care of myself. I was finally being healthy, whatever that was supposed to mean. No one, not even the mental health care professionals in my life, expressed their concern to me, even though a drastic change in weight is a very well-known sign of poor mental health. I want you to know that that doesn't stop being true if the individual was heavy before and thin now. When I was able to start eating again, of course, I began to gain the weight back. My primary care physician, who was informed of my history with trauma and mental illness and disordered eating, looked at the scale as she weighed me and told me she liked me better 30 pounds ago. I know she said it exactly that way because it echoed in my head for months afterwards. Feedback like this certainly made it hard for me to believe that I was doing the right thing by recovering, which for me meant eating enough and filling out. I haven't escaped this bias where I go for my therapy now. I had to request a new therapist after the first woman I was matched with responded to me explaining my body insecurities with a warning about eating too much junk. I hadn't told her anything about my diet. The nurse practitioner I see once every 3 months for a check-in and a medication refill began a recent appointment by weighing me, pretty standard for a change of dose or checking how the body's responding to the medication. But when I sat back down, he asked pretty sternly if I exercised. I asked if this was about my weight. He replied that, well, yeah, my BMI was pretty high, and that's how an appointment to discuss how my medication was working for me became another lecture about my body. I wish I could say I wasn't used to this. I wish I could say that my heavier friends aren't used to this. I left the nurse practitioner's office that day in tears, and I had to use the following appointment with my new therapist to process the shame I'd experienced in her own practice rather than what I'd actually come in to discuss. The judgment that heavier individuals face in healthcare results in shame, disgust with oneself, and sometimes anger at the system, never comfort or safety or consistency, which are all essential for recovery. So as we work to reform our mental health care system, I'd really love to see an awareness of the very real discrimination that bigger-bodied folks face every day in the healthcare sphere. I know I might be telling you this for the first time, so I thought you should know that there's been much research done on this subject, and I think it might help to look into it. I'd love to see existing trauma sensitivity training be more inclusive of poor body image and disordered eating, and especially how those things are experienced differently by folks with diverse bodies. This is an issue that's incredibly important to me and many of my friends in recovery, so I'm grateful for the opportunity to bring it to your attention. Thank you for your time, and thank you for listening.
Okay, we have Allison.
Hi, my name is Allison Hall. I also work with the NAN Project. I'm 19 years old, and I have struggled with suicidal ideation and suicidality my entire life. I grew up in several abusive situations, to the point that this translated into my own abusive behaviors. In school, I struggled with my anger and making friends, and this turned into consistent bullying. At the age of 14, I was arrested for domestic assault after a fight with my mother. At the time, I felt the resources I had been given would not actually help me. I was using negative coping skills such as self-harm and having suicidal thoughts. Eventually, I was told that I could no longer rely on my mother and my therapist for crisis intervention, and I had to call these crisis lines instead. I am very grateful for the people and the skills that have gotten me this far, but I strongly believe that crisis lines can be improved to better support the people who call them in times of need. When I am in crisis, I struggle with seeing things in a tunnel-like vision. I would not see any of the skills that I have available to me at the time. Sometimes, I just need to be reminded of the coping skills that I have in my so-called toolbox. This allows me to calm myself down and stay out of the hospital. I needed to know at the time that I was not alone. Instead, when reaching out to the crisis lines, I was often immediately told to call 911. When in reality, all I needed was someone to listen long enough to refer me back to the strategies that I already knew worked. Unfortunately, at the very beginning of my mental health journey, I called these crisis lines and often ended up in the hospital. This created a hospital dependency, and I was in and out of programs for 2 years. I didn't realize that I could have a life outside of the hospital by utilizing community supports. My family and I hadn't yet figured out that I needed to learn how to live with my chronic suicidality in order to feel better and get well. I truly believe that clinicians that work on crisis lines need more training on how to identify when clients need immediate attention from emergency services versus when they just need to talk or de-escalate. For a really long time, I was scared to access these lines as I felt I would just be sent back to the hospital when I knew I didn't need to be. Because these lines did not understand how to support me, I had experiences where calling crisis made my situation scarier or even worse. With more oversight and training, I believe that crisis lines could be improved for their employees and volunteers. Many callers will benefit from referrals, education about available outpatient services, help accessing safety plans or other supports and coping strategies, rather than having crisis teams or first responders called. Being under so much pressure, I do understand the difficulty of the job, and I understand the need for immediate attention in some cases for certain clients. However, this is not needed every single time. I am incredibly grateful for what has worked for me in the past, such as many different coping skills, family and friend support, and several programs such as CBATs, ARTs, and residentials. With the improvement of these crisis lines, I strongly believe that more people will feel greater support during difficult times and be more willing to reach out for help. Working with the NAM project, I hope to continue to educate young people about the matters related to mental health and inform people in all walks of life about the issues which are important to me. Thank you for listening.
Hey, we have, is it Delise? Hi.
Hi. First of all, thank you so much for doing this. It gives us parents so much hope for our kids. We adopted 2 foster children. At the time, it was DSS in Beverly, and then we were switched to the Lynn office. Stephen, our son, was born 26 weeks in gestation. His birth mother was using between 5 and 15 bags of heroin a day for the entire pregnancy. When Stephen was born, he was basically a floppy fetus. He had no APGAR scores. There was intracranial hemorrhaging. He had 21 diagnoses at birth. We were given the kids by their grandparents, and Kelly was fetal alcohol syndrome. So immediately, as soon as we were restricted foster parents, we kicked in, and we had everybody there, visiting nurses. Everybody was in and out of our house all the time. Through the years, things progressed. We were involved with DSS, DDS, DMH, DCF, a CHINS for Kelly. We're currently involved with DMH right now and DDS. Stephen is 24 years old, and right now, because he's autistic as well, the dual diagnosis presented at Ivy Street in his senior year. So autism has now entered into our journey. We've been out of placement district in Manchester, Essex, the Solstice School in Raleigh, St. Anne's Home in Methuen, and IRTP at Tewksbury State Hospital, Dr. Franklin Pierce School in Bolton, Devereux School in Rutland, Ivy Street in Brookline, Essex Academy in Methuen, North Shore Academy in Beverly. We've been to Beverly Hospital, Salem Hospital, Union Hospital 7 times. 1 was for 4 months. Anna Jakes, 5 placements there. Hampstead, Arbor Fuller in Brookline, Children's Hospital in Boston, Fuller in Attleboro, which is the only one, by the way, that services autistic kids. So now when Stephen is hospitalized, last year it was, I think, almost 14 times, we had to go to Attleboro for services for him with the dual diagnosis that's presenting a little bit differently, and I think it's kind of new, but I think with all these kids coming up with autism, most of our friends and parents through these all different schools, we found that most of the kids have had dual diagnoses of autism and mental health. And I know that's something that hasn't really been addressed yet, because I think the opioid situation and Stephen being on methadone for 29 days as an infant and his body shaking so incredibly, it was just amazing holding him. But, you know, through the years, he's a bright, intelligent, high-functioning, autistic young man now with mental health issues. He was diagnosed with the schizoaffective disorder, come to find out because of the medication that the IRTP put him on that was causing all of the psychotic situations. So he took himself off medication in November. He went to Fuller for 16 days, took himself off the medication, and now he's diagnosed with major depression disorder. So we ran into all kinds of, these two kids have just brought us on a path and a journey that, you know, most parents in our situation, we walk on eggshells every day, but I think we've learned to walk on them through these years. Right now, he's living in a group home in Ipswich at Agawam Village through Elliott. But the residents there, I think there were 4 over 60-year-old women and just 2 young adults at the time, but I know they're in the process of trying to turn this into a young adult living situation. But again, no one speaks autism in that environment because they're all DMH trained and not DDS trained, and it's getting so complicated for autism and mental health. It's just, but I think there's so many families coming forward with these dual diagnoses. So when we go to the hospital, which is quite often, we get placed in the hallway bed because he's not bleeding and he's not throwing up and he's probably safe to be in the environment. And we're usually placed with 3 or 4 other families in the hospital bed. But when you're sitting there and you're full of anxiety and your child is in an episode and you can't give them any medication at that time because you haven't gotten the orders from the group home, it turns into a different situation because you're watching people with heart attacks and bleeding out, and everything is going by you in the hallway. And you're there for mental health reasons. And so when the kids come into the hospital, I don't think the ER is the best place. I wish there was some other pod, or why can't we just go to like a psychiatric hospital? Probably because there aren't any, but it's come into that whole situation where I think the whole thing needs to be looked at again, and I'm so glad that all of you are here helping, and thank you for helping us along the way.
We had Josh next.
Hello. My name is Josh Levine, and I am an in-home family therapist and soon-to-be intensive care coordinator that works for Leahy Health Behavioral Services, also Beth Israel Leahy Health Behavioral Services. I'm currently a social worker, and I have worked with many different families with many different behavioral health needs, especially with children ages 4 to 22. The biggest barrier I currently see with people experiencing, especially children experiencing behavioral health crises, is the lack of clinicians at mobile crisis or emergency services. Recently, I was with a family with a child age 9 years old who's going through a crisis due to a psychiatric emergency. I had them call mobile crisis, and they were told that the emergency clinician could not come to the home until 3 hours later. That was due to only one clinician being on staff that was serving the entire Northeast. That is unacceptable, and this youth needed immediate psychiatric emergency care. So I had them call the hospital, bring them to the emergency room, although the mother wasn't able to provide transportation for the youth due to escalated behaviors. So the youth needed to be restrained in an ambulance, brought to the emergency room, where they needed to wait an additional 3 hours to actually be seen by an emergency services clinician after they were deemed to be medically cleared. There needs to be more of an incentive for emergency services clinicians to be working right now. Additionally, emergency services need to have more staff and better response options. Emergency services right now simply refer to other long-term programs where the person is to be placed on a long wait list. Currently, I have a colleague who has talked with other clinicians in other states, and currently in Virginia, my colleague has talked to someone in Virginia where their crisis clinicians have a wait time of at max 45 minutes. That's what we need to have. The reason why Virginia has a response time of 45 minutes is because their state has provided enough money to incentivize emergency services, mental health clinician jobs. That's what we need. We need the states, especially the insurance companies, to provide effective funding for emergency mental health clinicians. Right now, in my job as an in-home family therapist, intensive care coordinator, I feel that we have a burden right now from the insurance companies providing not enough funding, and due to that not enough funding is providing a lack of clinicians, which is resulting in a much higher caseload, providing not enough time for us to spend with our clients in need, not enough care that we're able to provide. And there's constant audit checks when there is just not enough of the high intensity of casework that needs and clinician training and skills that needs to be provided. Additionally, I work with in-home family therapy and intensive care coordination, which is provided by the Children's Behavioral Health Initiative. This currently only accepts Mass Health, and this is a huge barrier to families who have private insurance. I recently was working with a family because there are children who are not under Mass Health who also have behavioral health needs. I recently was working with a family. They had to pay about $1,000 out of pocket a month to have in-home family therapy services in their home on a twice-a-week basis. That is not covered by the insurance, which needs to be. In addition to the lack of clinicians in emergency services, I am constantly seeing, again, long wait lists, which is additionally because of the lack of funding provided through insurance companies and provided through the state in general. One big thing in reference to wait lists is there's a huge wait list for outreach services. And again, a big reason for that is because clinicians don't want to go into outreach work. They want to stay in a siloed clinical agency. And again, we need, especially in terms of funding not only for mobile crisis, but for outreach positions. There needs to be funding and incentivization for outreach jobs. Additionally, in terms of the various outreach agencies and clinics, I'm suggesting that there needs to be a listing of all outpatient clinics and outreach services in the area, because right now, myself and other providers don't know of the many different myriad of smaller agencies in the area. We just hear about word of mouth. We need, similar to the Massachusetts Association of Behavioral Health, MABA, we need something similar to that for all of the different agencies providing different kinds of services in the area. I also want to point out that whenever I'm talking with clients, I feel that they constantly need to share their life story with every single provider. I'm also suggesting to limit this kind of sharing of a life story to be able to have a single kind of transparent assessment between all different providers in Massachusetts, which will provide a much more comprehensive detail where you can actually get more work done with the client instead of just asking about history constantly over and over again to provide to every single provider. So I think that's all I have right now, but I thank you so much for this.
Okay, I think we have Ida next, and before she speaks, I just want to mention that it is now a little after 6, And as I said, we're going to hang out here and we're going to listen to people, everybody who wants to speak. But I do know that I've seen some people start peeling off. They probably have other obligations or other things that they have to attend to, given, that the time schedule was 4 to 6. So if you, for whatever reason, need to leave, and I just wanted to make sure that you did not leave without and on behalf of my other panelists, thank you very much for coming. And remind you, I'm going to, I'm just going to move this up to where you can also send in comments and requests at the website that's there, and it's also on the handout we have. But I did want to just, make a statement to make sure that you all know how much we appreciate that you have been here and you're sharing with us, and we're going to keep going. And hear now from Ida. Please come.
Thank you. My name is Ida Shaker. I speak today as a concerned citizen and a parent of a child with behavioral health needs. When my daughter's behavioral health issues escalated at school, I requested information regarding therapy from the school's adjustment counselor, weekly, for almost 2 months before managing to find one on my own, and when I did, the waiting list was over 6 months long. Had I received a list of recommendations or organizations that could help when she was initially identified as having social-emotional deficits, her needs could have been addressed sooner, and I could have prepared myself to better advocate for her needs. The earlier behavioral health issues are addressed, the better chance we have at treating them. And for children to succeed academically and socially, they need to feel safe. We need to bridge the gaps when it comes to the well-being of children, especially the ones struggling emotionally and physically. Studies have shown that children who experience trauma or whose needs remain unmet are significantly more likely to engage in illicit drug use, criminal activity, and have greater difficulty gaining employment. And I believe suicide rates are also higher among this population. I'd like to spend just a couple of minutes focusing on what communities do have access to but are underutilized or not utilized due to lack of community support or community awareness, in hopes that engaging them sooner, we can reduce the need for crisis care to begin with. Gloucester has about 1/4 of students identified with disabilities and more than 1/3 economically disadvantaged. These children are statistically more likely to experience trauma. Families need information and resources in order to be equipped to face some of these unique challenges. Organizations like CPAC, NAMI, and FACET are meant to help voice the concerns of the community, provide education and advocacy, advise the district, and facilitate community engagement, yet they either have little presence or families don't know of them. In fact, several years ago, our district chose to bypass the state-mandated CPAC requirement with little or no effort to establish one, and as the waiver is now expiring, CPAC is struggling to obtain the resources necessary in order to help our children and reach our community. Also, the CDC has an ongoing study called ACE, an acronym for the Adverse Childhood Experience, which has collected a wealth of data and resources. I hope we will be using this information when developing community initiatives to help mitigate the challenges and collateral damage caused by addictions, behavioral health issues, low income, and violence. Lastly, I understand the heavy burden on educators to ensure the highest standard of academic instruction while having to manage behavioral issues. However, many of us understand that behavioral issues are often symptoms of an underlying need that has not been met. These children are often identified as problem students, which unfortunately harms their sense of self-worth, leaving these children more susceptible to falling through the cracks in our mental health system. And since children spend much of their time in schools, educators are privy to many of the warning signs. Schools could and should provide families with a list of resources and organizations such as the one stated in order to reduce the barriers to treatment, access, and advocacy resources. I'd love to be able to identify exactly who is responsible for these unmet needs, but the reality is that we need a true collaborative effort while understanding that a child's needs must be identified and addressed at home, at school, and in the community. We absolutely need an integrated approach to secure a well-adjusted and prosperous future. This is our duty. In order to better understand the needs of our most vulnerable citizens, we need better community engagement efforts. We need to understand and work with families, not against them. Thank you very much.
Okay, we have Martha.
Hi, I'll be fast. For me, the major issue is money. I looked up some statistics and I assume that Massachusetts is somewhat better than the rest of the nation, but mental health and behavioral health is now either the first or second most diagnosed treatment issue, and the money that they have provided for that has not changed. And what that affects is the kind of people you can get to stay in the field, the caseloads, the kind of efficiency of services. I do outreach, I do provide rides, and I started as an early childhood person working for Sue Todd, and I have been an outpatient clinician for 11 years. But the work is hard. It's really hard. It's multi-generational, and in spite of brief care, brief services are a good thing as a stopgap measure. But I have worked with a lot of my kids for 15 years, and that doesn't happen often, and it means a lot to them. I've been supported by an agency that pays me pretty close to enough money to live on at this point in time after 11 years, and many do not do that. I can't complain about the money I personally make, but I think this whole idea that the mental health and the opioid crisis fell out of the sky is maybe one of the most ridiculous concepts I've ever heard in my life, because I have lived here a long time. I've known people that have overdosed since the day I moved in, and I went to the funerals with 2 of those kids that Sue talked about. So I think people have to get over the idea that this is all going to change fast. Kids that have, parents that are addicts or substance users, it doesn't go away for them, ever. So I would ask that people look into spending and investing more money in paying people enough so that they will do this kind of work for a longer period of time and accept the fact that kids and their families might be in treatment for quite a while. So, thanks.
Okay, next we have Joe.
Good afternoon. I'm privileged today to present some brief remarks on behalf of the Northeast Recovery Learning Community at the Northeast Independent Living Program in Lawrence. We provide peer-driven peer support, training, and consultation in 69 Northeast area communities in Eastern Mass. I'd like to start by talking about the primary importance of making a healing connection in our mental health services. Regarding the issues before us today, we want to emphasize that as peers who may seek damage-funded services in time of great pain and difficulty, many of us, most of us, want interventions that will help us get in touch with our strengths rather than focus on our weaknesses. The biggest single gap in public mental health services today, regardless of where they occur, is a primary commitment by all staff to connect with the individuals coming to them to build and maintain mutual relationships. This approach is currently being implemented by Bay Cove Human Services, one of DMH's largest vendors. This agency has chosen to require all of its staff in its ACCS program, both peers and clinicians, to receive education to enable everyone to use an intentional peer support framework when working with program participants, regardless of their specific role. The model of intentional peer support focuses on how to connect, build, and maintain genuine human connection. It is a proven approach to promoting overall emotional wellness. Connection culture, in fact, is not only the purview of progressive peer support practice, but has also been proven to provide wellness, to promote wellness and effectiveness in boardrooms and business environments across the country. Numerous resources are available throughout Massachusetts to promote this and other alternative ways of providing mental health support to individuals in distress. Another issue I have is the need for better information about the effectiveness of peer support and peer services. Even today, nearly 20 years after the introduction of certified peer specialists in Massachusetts, most providers still lack a good understanding of the unique roles we can play in a person's recovery and what CPSs can and cannot do as they seek to ethically implement their roles. More education is desperately needed to ensure that trained peer supporters can carry out their crucial duties in an unfettered way. Turning to emergency room issues, many folks who are evaluated in an emergency room come out of a desire to get distance from the problems they are dealing with. However, due to a lack of resources, the only available choices are often going home or going to a traditional CCS or respite unit for a few days where they may be forced to take medication they do not want. If the person has transportation, they may get referred to the one peer respite that exists in Massachusetts, a FEA, sponsored by the Western Mass Recovery Learning Community. Unfortunately, the peer respite is in Holyoke, not an easy place to get to for the average person living in Eastern Mass. There is a great need for at least one peer respite facility in Eastern Massachusetts. Funding needs to be provided for this invaluable alternative. This kind of home-like setting provides a voluntary break from the stressors that may have caused a person's crisis. Peer respites are a type of respite that is staffed only by peer specialists, and staying at a peer respite is voluntary. This is great for someone who wants to get away from what they are going through and talk to someone who has a first-hand understanding of what they're going through. The final issue I have to address today is that here in the Northeast area, we've had a historic concern about access to appropriate services for cultural and linguistic minorities. As the only agency to have sponsored a bilingual peer support program in Massachusetts before CPSs were even a thing in this state, we know that many children and families, as well as adults, are shut out of a system which is failing to provide culturally competent care that addresses their unique issues and concerns. Massachusetts must do more to stand up for these individuals, aggressively recruiting peer supporters from minority groups and providing greater incentives to minority providers to contract with the department to provide services for our communities. The Department of Public Health is leading the way in promoting initiatives to address the sad facts of unequal access to physical health care. DMH must do the same. We, as a recovery learning community, stand ready to assist and support all efforts in these areas. Thank you for attention. Thank you for your attention, and have a good night. Thank you.
Okay, next we have Amanda. Wait, Amanda? Did she leave? Did she leave? Okay. If someone knows her, if she had something she would like to submit, we would like to know about it, so remind her if you happen to know her. Next we have Thomas.
So I actually was planning on coming up and speaking about exactly the same things that Jill spoke about. So I'm just going to elucidate on some of that. Just want to back her up on what she said about the intentional peer support. I was one of the people who helped bring that to Bay Cove, and it's really transformed the organization. Interventions with people who are in crisis have just become deeply human and humane. You can just see that people have embodied a new way of being with people, and it slows the process down when people are in crisis. And instead of always jumping right to a section, we're having conversations with folks and finding out what's really going on. And what we find out often is just being listened to changes the intensity of the crisis. So I am a peer specialist and peer coordinator at Bay Cove, and I'm trained also as a clinician. And when I was doing a 2-year internship on a crisis stabilization unit in Boston, I saw some things that were just not good as far as like supporting people move through a crisis and move forward. Staff not understanding the experience, the internal experience that people weren't going to, sometimes humiliated folks, or were harsh, or maybe treated them like they were less than equally human. And I'm being a little critical of the system, and I want to say at the same time, on the same unit, I saw beautiful practices being carried out. But I saw too much harm being done in that. And I think one thing that would really help in crisis intervention is to involve peers more. We know what hearing voices feels like. Sometimes it can be really horrifying. We know what suicide feels like and how hard it can be to stay alive. I am somebody who struggled with suicide for over 33 years of my life, and also has heard really, really horrifying voices. What people are often looking for, or one of the main ingredients that people are looking for when they're in a crisis, is to be understood. And often needing a connection at the place which usually drives people away. And so what we do as peer specialists is that we connect with people. Our whole training through the Transformation Center is around connecting with people. And often when that connection happens, things start getting better. So there is some research that shows that suicide actually increases after hospitalizations for suicide. Some research shows that. And I think that what that's often linked to is some of the coercive practices that are involved in the crisis intervention practices. I know that people don't intend to cause harm, that's really clear, but sometimes not having enough information on what that experience is like for the person, some harm is done, just through a little bit of ignorance perhaps. But in AFIA, what Joe also talked about, the peer run respite out in Western Math in Northampton, what we see there, what the research shows is that suicide actually goes down in the 2 years after the AFIA experience. I've talked to so many people who've had that experience, had really long conversations about what helped them, and it was that connection. It was being set with. Sometimes just knowing that someone understands what you're going through is just sitting there in silence overnight. That's the thing that one person said was the most helpful. So some thoughts I have. I agree that it would be wonderful to have peer-run respites. I have a number of them even in the East. And then also maybe other creative ways of having peers involved in the crisis response. Maybe you have a peer-run crisis response team, and that's just peer specialists. Maybe try it out, see how it goes, collect some data on that and see what the experience is for folks. And then again, having peers in respites and crisis stabilization units is a really good idea, but I just wanted to make it clear they really need to be supported and respected in that environment. If they're not respected, if their values aren't held up, they can't do the work that they really need to do. It just becomes a battle. So thank you so much for your time.
Okay, we have Anna.
Hi, my name is Anna Baglanea-Sieves, and I'd like to talk today about the lack of mental health services for people with developmental disabilities, especially those who are nonverbal or on the severe end. Basically, they are non-existent whatsoever. I know people like to think of people with Down syndrome as being happy and huggy, but they're people, and because they are people, they are susceptible to mental health crises just like everybody else. And I know that because my son went through a mental health crisis, blindsided us at the age of 24. He became psychotic and aggressive, and after one episode of not sleeping for 72 hours and being extremely aggressive, we ended up at the emergency room where the mental health crisis person was called, and basically verbatim what she said to me is, "What do you expect me to do with someone like him? I don't have anything." We were given some Ativan and sent home, and that was basically how we for the next 3 years, negotiated his mental health crisis. We gave him Ativan when needed. Fortunately, his day program didn't discharge him because his behaviors became severe at his day program as well, but they worked with us and helped us work through it. But we never did find a therapist for him. When he was 12, after his father died, he also had some mental health issues, and we were able at that time to find a therapist who worked with people who were nonverbal. She did EMDR therapy with him, and that was very, very helpful. Unfortunately, several years later, she died, and we were not able to find anybody else. So with his doctors at the Mass General Down Syndrome Clinic, we sort of cobbled a team together to address some of the issues that he had. But as far as like a therapist or somebody who could help us in crisis, we never really found anyone. I did contact his DDS caseworker to let him know that we were in crisis, that we needed help. And basically what he said to me was, if you feel that he's a danger to himself or others, call 911. Other than that, there was nothing. I later learned that Hogan does have a stabilization unit, but it is very difficult to get into, and my DDS caseworker didn't even tell me about it. We were able to, it took about 3 years to get him completely stabilized. In 3 years, we couldn't take him to restaurants, we couldn't take him out. When I took him to Mass General for his doctor's appointments, we had to be escorted by security because he would lash out, and he had a lot of outbursts, which was very unlike him. But really, because of the day program staff and his doctor's willingness to give us a PRN for Ativan to calm him down when he was really upset, and trazodone to sleep, that's how we got through it. I called many therapists, even people who were recommended to us who work with people with developmental disabilities, but because he's nonverbal, they wouldn't take him, or if he wasn't going to the right day program and they weren't familiar with it, they wouldn't take him then either. I'm also the vice president of an organization called COFAR, Coalition of Family Advocates. So, and we deal a lot with people with developmental disabilities and the issues that they face. And this is an issue that we hear about very frequently. Nonverbal people with autism, Down syndrome, other developmental disabilities, there just isn't anything out there. Basically, I know of families who are just, they pretty much they're getting beat up every day by their children. And there's really no help for them. There's no help if you go to the ER, they're just gonna send you away, and it's very difficult to get help for people. I mean, it's just, we really never found it. We were able to stabilize him and then get him into a group home situation where he was happier, because part of his mental health crisis was a lack of work, and also a lack of independence and frustration around that. So he's doing much better now, but that's pretty much it. We got to book the mental well-being of people with Down syndrome, and sort of read that cover to cover, and then did what we had to do for him there. But it's something that DDS really needs to work on. In terms of getting mental health to especially nonverbal people, because they're, nonverbal doesn't mean non-feeling, non-thinking. They're going through everything that everyone else is, but they just can't communicate it. So, thank you.
So we have Carol. Thank you. Next person on the list is Carol. Did she leave? Carol McNair? She must have had to leave. Okay, so then we have, is it Valerie or Valeria? I wasn't sure how to pronounce your name, so sorry.
Thank you so much for having me, and thank you for your work. I'm Valeria Chambers. I work at the Transformation Center for 16 years. I work as the Community Voice Research and Policy Coordinator. And one of the things that we're working on is working with researchers that address disparities. Several of the people I work with have come forward with real concerns about feeling discriminated against because of their race or because of the language they speak or the way they look, the way they act. Their symptoms are misconstrued or misunderstood by the clinicians, misread, and this has vast effects. Oftentimes people make choices about treatment modalities based on whether or not they have experienced discrimination by a provider. Also, discrimination affects people's health. In our work with Ben Cook, a disparities researcher at Cambridge Health Alliance, 42% of Blacks say they have experienced violence or threats because they are Black. 51% said they have personally experienced people using racial slurs or negative comments. And 22% said they avoided seeking medical care out of fear for racial discrimination. We need peer support services that have been molded to fit the culture and linguistic needs of the person. We need to increase access. Peer support should be the first door. 3 ways I'd suggest: expanding the physical environments in which services take place, providing cultural and linguistic congruence of providers with the person served, as well as offering a person-centered approach as to style and type of individualized support given. Culturally responsive approaches to mental health care, including peer support, done by people who have lived experience of those cultures and languages. Treatment and peer support opportunities in spaces that Blacks and African Americans feel safe and comfortable in, where their own wishes and needs are also taken into account. And finally, flexibility in treatment or service modalities, such as one-on-one peer support in the home, neighborhood, places of worship, community centers, etc. Thank you so much for your time.
Next we have Deborah Delman.
Hi, everybody. Thanks for staying. For the last a little more than 2 decades, I've been the executive director at the Transformation Center, and but moved on from that role in the fall and completely left the Transformation Center in February. In Worcester listening session, though, currently I'm part of the State Mental Health Planning Council and a subcommittee to the Planning Council, Transcom, that really looks in closely at both the certified peer specialist role, funded through the Department of Mental Health, and the recovery coach role, funded through BSAS, and also at the young adult peer mentor role, also, funded across the system. And so I'm really here to support the voices we heard in Worcester's listening session, where, a few of the marginalized community representatives got up there from the Asian community, the Latin community, the LGBTQ community, the Black community, and the deaf community. All, we heard voices from those groups, and I would recommend that, and we would recommend that your leadership team work with the Transformation Center and also receive a presentation by the Health Equity Research Lab at Cambridge Health Alliance, and also the Disparity Solutions Center at Mass General, that we've worked closely with, specifically around culture and race access that Valeria was speaking of. We'd like to say that the mechanisms that create disparities have not been impacted or helped through the ACA and the integration work in Massachusetts. All boats are rising in terms of integration of behavioral health care, but disparities are not impacted and remain really solid and resistant to that change. And a major mechanism that we've been looking at with these research centers is that individuals of marginalized communities nearly uniformly report unfair treatment by staff, including and especially by doctors and nurses at their healthcare settings, that results in people not returning to care if they come at all in the first place. And it bears out, as we all know, over decades of looking at this, in prescription disparities, in disparities of disposition. Does a person go to the hospital or is incarcerated? Even, recently there was a beautiful thing done by PAL, Parent Professional Advocacy League, looking at wait times in the waiting room. There's a disparity there that they were able to document. And also in several things, a recent thing done by the Chinna 17 around looking at blacks in mental health documented yet again that while clients are reporting an experience of racism or unfairness, providers are saying, oh, racism isn't a problem here. And so we have an issue, but the second recommendation, I was hoping that you'd think seriously about looking at certified peer specialists as part of the solution, and also, although I can't speak for recovery coaches, we're working in Transcom for recovery coaches in that role. Really decades of work around mental health stigma and around oppression, LGBTQ, racism, etc., shows that yes, laws, regulations, and standards are a must, and we want to see stronger standards in this forward-looking system, but also it's people being in contact with each other, getting to know and trust each other and working together, and that's where these peer supporters on teams can be so profoundly impactful in access. And yet it's urgent, while the DISRIP funds are available, while they're here to work with, to look at this two-way street of workforce development. It's not a simple process. For example, the double sort of marginalization that occurs when you have both an identity that's oppressed based on race or language, first language, and a mental health condition. You have to create jobs to call people out of the closet. As a white person who came into this mental health movement with my own recovery needs, it was the job that brought me out, and lots of the white CPSs that are out there. And so working together in this DISRIP moment is an opportunity to work with the job makers in the healthcare system, create those jobs, and develop specific, as Valeria was saying, culture-specific, nuanced work. I want to say the Transformation Center, I can end pretty much there because we're going to provide written testimony that is very specific, related to affinity groups of deaf, Latin, Black, LGBT, Asian communities, but that two-way street of the organization crafting a job description that allows the person to assist in that process. And the second piece is crafting the preparation of the workforce to be ready for a really challenging environment where they're bringing this message, making relationships from the lowest standpoint in the hierarchy within an organization. And I would just hope that you could take a look at our written testimony as well.
Okay, we have Zena. Zena Lane, did she leave? No.
So I am speaking in a different angle. I'm a mother of 4 children, 2 of which are severe mental health patients, and 2 of which who are now dual diagnosis. So my journey began 5-6 years ago as all of my children were beginning diagnoses, and I became the revolving door of services. I have dealt with DCF, DDS, DMH, and several other entities. The biggest things that I find that are the struggles right now, my son was one who had severe mental health issues. He went from diagnosis to diagnosis, medication to medication, And in the meanwhile, I had to stop working to deal with everything going on in my home because I, like one of the parents earlier, was found to be a parent who wasn't taking care of her children in what people thought should be the right way or providing what needed. So then at that point, my husband decided to work 60 hours a week in order to provide for our family so that we could live and get the services needed for our children. I have, in the 5 years, multiple times struggled with myself being so tired and worn out that I have been on the verge of a breakdown because so many people, as many of these workers that have come in and talked, have come into my home and they can't stay. They get paid for a temporary amount of time, or they have to leave for a better paying job. It becomes both extremely difficult for me as a parent trying to work with my children, and for the children who then go for another period of time without services. Number one, I need them to be able to come into my home, which they need to be paid more money in order to do that. And they need to be provided with more services to give my children, because I do not have the ability, with 4 children on different diagnoses and 2 on the spectrum, to be able to travel everywhere in the state of Massachusetts to get them services. I also experience the endless paperwork with them and agencies that have to come in fighting over who should be the one involved to fill out the paperwork for insurance companies to pay. I have Harvard Pilgrim as a primary because my husband works his job. And then the secondary, I had to fight for 3 years to get Mass Health to actually agree that my children were disabled in order to get it. So for that aspect, I really feel that our workers, one, we need dependable paid workers who can come into our homes in situations like this to work with us as parents, because we can't become very exhausted. And at that point, you become the ones who are taking care of us. Then where do our children go? They're no longer in our homes. And that saddens me. So that's the first point. My second point was, at one point, I did come to a point in my life where 3 times I had to hospitalize my son on the mental health spectrum. I was very upset with the way I was treated, like the mother who prior spoke. Because my husband was unable to come into many of these things with me, and I had to search for people to come in and help me with the paperwork, come in and get me there, whatever the case was, so that I could get the services for my children. It became very difficult with the way that these people were dealing with me. They, at times, would be rude. They would be frustrated. They wouldn't explain to me what they would like to give my son as meds. They would expect me to try to get the insurance to pay for things that at that point couldn't. And then when I reached a point where maybe Mass Health wouldn't pay anymore, or Harvard Pilgrim wouldn't pay, my son was kicked out of their facility or sent on his way with no follow-up, and I was just told to continue the services I had that were no longer working. That happened 3 times. I finally, at one point, got DMH services, and in my home in DDS, like I said. I have found that they need more support as well. They need to know, and they need to continue funding, but the funding needs to be used appropriately. I have found in the last 3 years, they have tried to put my son in programs that claim they are DMH for the summer facilitated. They are not people like these people coming into our homes. They get paid ample money to be trained to take these children, yet they can still take your money and then turn our children away. That is not fair to parents like us trying to work with these people who are trying to help us. Your money needs to be better used. It needs, if it needs to be a little bit more at times to pay for these people, then it needs to be, because when you're paying $5,000 for a camp far away in New Hampshire, number one, you've got a parent like me making the effort to fill out all of that paperwork and get your workers to do all of that and get that child there. And then for them to not stay, it is quite the disappointment. And then once again, the parent has the responsibility with your workers to deal with this child. and their needs. So that's my number 1 point. And my number 2 point was I had recently reached the age in my 2 eldest where they had the dual diagnosis of autism as well. I heard another mother speaking on that. And they got to the age of 13. As they were younger, there was very little, but I have found that ABA is a service that is spectacular. I wish that you guys could fund ABA as much as possible. ABA is something that autistic children, as they grow, it can help with these behaviors and it can keep them from these facilities. ABAs are very expensive, I understand that, but they are very important and they do a very important work in keeping children in a very safe and very therapeutic environment, and they facilitate us parents in a way that we can do that. So that was the other thing, and I feel that DDS needs to be a little bit educated on programs like that, and they need to fund some more facilitation like that, because I, as a parent, had to pay for that privately through my own insurance. And a lot of the programs, when my children got the dual diagnosis, I went searching for, which I feel as a parent is a discouragement. It is exhausting. And I do feel that it is important for you guys to do it, because if not, parents like me will then become your DMH clients, and that is the last thing that you want. So please help us keep our children safe and healthy, and fund some of these things, help educate these people, and keep these wonderful people that are trying to bring in these programs. Give it a chance. See if it's successful. Send your people in and find out what's working and what's not working. And if there's stuff that's not working, don't be so quick to get rid of it. Fix it so that it can continue to help us. Thank you.
I have one more person on the list, Eva.
Hello, thank you for staying, everyone. I'm Eva. I'm an occupational therapist. I've worked both in inpatient mental health in Dorchester on the adolescent, adult, and geri psych units, and then right now I work in community mental health in the North Shore. So I see clients from PUD to Gloucester. And first, I just wanted to thank everyone for sharing and all of the mental health consumers and families, because that's really important for clinicians to hear. And first, I just wanted to introduce occupational therapy. I'm not sure how many of you are familiar with it. Right now, there are 2 bills out in the Senate, number 550, and at the House, it's Bill 1000, and that's to get occupational therapists qualified as licensed mental health professionals. So OT has always, since it started, worked in mental health, but right now it is not, we're not qualified as licensed mental health professionals. So I am lucky that my agency employs me in outreach. I see clients every day in their homes and in group homes, but that's not always the case. We are really important to mental health. We're a strengths-based approach, and we look at the person, the environment, the occupation, so that's the activity that they're actually doing, to try to improve functioning. So we are seeing clients and not just looking at their diagnosis or trying to stabilize, we're trying to get them to improve their functioning and do the things they need to do. Do they know how to ride the bus? Do they know how to manage their medical symptoms? Can they self-regulate? We look at their sensory processing. Are they able to take in the stimuli in the environment and modulate that so that they can control their body and respond accurately to it? We look at their cognition and try to figure out, is this just an executive functioning challenge? Can we help with attention to get tasks done? Or is there, something more going on? Do they need to be referred? So that's kind of what OT is. And I just wanted to reiterate to the families who shared, there are so many individuals with developmental and cognitive disabilities who also have mental illness. I believe the statistic is people with autism are 9 times more likely to be diagnosed with a psychotic disorder. Right now, I can say half of my caseload is individuals who have both intellectual developmental disabilities and a mental health diagnosis. So it's super important that we have clinicians who are trained to do both and are thinking of both. And that's where I feel like right now, a quick solution, OTs are trained in both and have had their field works that are required in schools, in hospitals, in mental health, in physical rehab. So while we're trying to fix the system umbrella, there are clinicians who would be willing to work with these populations and are trained to if there were positions even available. Yeah, that's kind of the basis. Thank you.
Okay, we finished the list of everyone who signed up to talk, and yes? Of course you may.
I came here tonight with my friend Zena, and we both have youths who are on the more severe level of behaviors. My son has multiple mental health diagnoses, and they're actually going back and forth between, bipolar, schizophrenia, and he's only 10. One of the things I'd like to say is there are some really great programs out there. There are some really great workers. Thank you to everybody who's still here, still listening. The only thing I would really like to see as a parent, definitely summer programs, because that is like the pit in my stomach just drops every time it's nearing the end of the school. Where are we going to put him? I set my son up in 3 programs this summer, and he was not able to maintain, unfortunately. And there are great staff people out there and workers. With that being said, we as parents with children with severe behaviors keep hitting this roadblock of programs just giving up and just releasing them from their program. My son went to SEAM Collaborative for the summer program, and in 3 days, they sent him home and said, this isn't the program for him. He's in out-of-district placement. He's not our child, so sorry. And they sent him home. Now, he wasn't super aggressive or assaultive. He just wasn't really adhering to the program, I would say. I don't know if you could find some ex-Navy SEALs or something, but we need people with the strength, the stamina, the determination to help our kids get through these programs. And it seems like the window for programs is getting smaller and smaller, unfortunately. I started my quest in February, and by June, we were still not sure where to place him exactly. And we placed him, and unfortunately, another summer in a row, it didn't work. So it would just be really nice and kind of like a weight off the shoulder to find a program that will stick in there with our kids and not release them. And some of our kids are tough. I get it, I know. My son, if I could describe him, he's like the smartest, happiest, funniest kid, but then if like Damien from The Omen and the Tasmanian Devil had a baby, that would be my son. So, who are you gonna get each day? You don't know. But the tough part is, there's so many parents out there who work and having to get that call to come pick them up because, they just can't hack it today. We just need somebody who's gonna say, no, we're not gonna give up on you. Yeah, I know you threw a rock, but let's work it out. Let's do that. And I think what would really help is if we can create programs, or if not, work with programs, and maybe even just train them some more so that they'll stick in with us. Thank you.
Thank you. Well, again, as we wrap up here, I'm going to ask everyone here to also thank you and say goodbye to you, but also I just want to remind you, if you have things that you brought that you would like to leave us that we can see that gets into the record, that's fine. You can also send them to the website and, stay involved and stay in touch as the EOHHS, rolls out this project. So do you want to say anything or wish people well?
Yes, thank you everyone for coming out and speaking. One of the things I used to do before I was at the Soldiers Home was I oversaw the statewide advocacy for veterans empowerment, suicide prevention program for veterans called the SAVE Team. As a matter of fact, one of the outreach coordinators was here, so here it helped me a lot here tonight to hear again about the importance of peer support. But I want to thank you all thank everyone for letting me be here to listen to your concerns. Thanks.
Excuse me, I just want to say thank you. It was very meaningful to be a part of this again, so I appreciate everybody's time and staying. Thank you.
Thank you. I appreciate all the heartfelt stories that we heard today. It's hard to hear how hard it is for people and how much pain everybody experiences. And it takes a lot of courage to come into a public place and tell everybody. But we need to hear about all the pain. And I appreciate that people were brave enough. Thank you. Sorry.
And I just want to add one more thing on the way as the microphone goes that way. I just wanted to say that, the stories you have shared with us, especially about your kids are so fortunate to have you as their parents, to advocate for them and to help them. And I just appreciate all of you coming here and sharing your stories with us.
It's going to sound like a little bit of a broken record, but it's humbling, honestly, to listen to the dedication and courage and hard work that you as caregivers, as providers, put into these kids, these folks who are going through these issues, and I think the way a room like this is sort of set up is you're all out there and we're all up here and you're talking and we're listening, but I think it's important to know too that mental health is not something that discriminates anywhere. So some of the stories that I hear tonight are experiences that I've gone through with my own kids and my own family members. So this is very much a all hands on deck kind of issue. So we're here representing our respective agencies because we want to improve the work that we do as a Commonwealth to support you as parents and caregivers and providers, but we're also consumers of a lot of the same services and people who experience many of the same frustrations and challenges that you do.
Thank you all. Your stories are what keep us motivated to continue the work of change, the work of improvement, which is so necessary. And when barriers arise, we can reflect back on what you've shared with us and keep in mind how very important it is, because every decision we make affects individuals and families. And we are dedicated to making the Commonwealth a better place for everyone who's touched by mental illness, substance use disorders, intellectual disabilities. So thank you for your inspiration.
I'll just echo the sentiments of my colleagues and thank you all again for your time and for your courage in sharing your stories. I certainly, and I know all of my colleagues, just share an incredible respect and appreciation for all of you, and both motivation and a heavy heart with how much work we have to do. We have a lot of work to do, and I hope that in the future, when we come back, we'll be able to say that we've made some progress together. Thank you.
And I just want to add one more shout out to your wonderful mayor, who looks like she might have something to say to us at the end. You're really fortunate to have a mayor dedicated to this topic who came and stayed for the whole thing. And Oh, okay.
Closely. I want to thank you all for coming because I was watching and you were listening. Because I've been to so many sessions. I've been in healthcare for 21 years, and I've been to these sessions and I've seen people, but you have compassion in your face. We're not blaming the governor. We're not blaming any of you. We're just saying that, you know what, you passed a budget. I know that it'll come with the session. It'll come with some meetings. We did it with the opioid crisis, and now you heard stories. You saw people. You know, people. With Anna talking. We think of children and health, and that the whole did a lot. The ones that have a voice. You know what? I have a nephew in counseling and children. I've heard the stories, but I want to thank you for